Let me go ahead and move the agenda along, and I'd like to introduce a man that needs no introduction to this crowd, Dr. John Ward. John is, of course, the director of the Division of Viral Hepatitis and the godfather of CDC's work on hepatitis C. So, Dr. Ward.
Thank you. I think when you started introducing, I was like, who is that person he's about to talk about? So I didn't know who you were. So, good morning, everyone. It's great to see you all here. I look forward to the discussion that we're going to be having because I think many of you in the room, what you do is the reason, I joined CDC. It's public health on the ground at the state and local level. That's where it all happens. We have a big health problem that I'm going to be showing you about more of in a moment. Hopefully you're already well aware of that. And what we're going to do today is come together to see what are some of the feasible strategies we can have going forward that can help us be more effective in our prevention and control of hepatitis B virus transmission and hepatitis C virus transmission and hepatitis C morbidity and mortality. Okay. All right, well, let's get going. So for the next few moments, we'll just give you a foundation of information to hopefully inform the discussions later on. We'll try to go through this expeditiously, but we feel like it's it's necessary to make sure we all get on the same page. Before I dive in, I do want to thank again all the ASTHO staff for putting this on, for beginning to work with us last summer to think about this policy change and to really put together a great meeting. So thank you all from ASTHO. And I want to thank Don before he gets up here in a moment to just thank AASLD, the American Association for Study of Liver Disease, and the Infectious Disease Society of America, who have really supported us in developing these panels and really helping us bring the clinical side closer together with public health. This policy development was really developed really sort of under the auspices of the HHS Action Plan, which came out as a consequence of the Institute of Medicine report on viral hepatitis that was published in January of 2010. Dr. Howard Koh, the Assistant Secretary for Health, wanted to put out a national plan in response to the shortcomings that were identified by that IOM report, and the result was this HHS Action Plan, which brings all the agencies together to achieve some critical goals regarding viral hepatitis prevention, care, and treatment. One of those were ways of improving testing, care, and treatment to prevent liver disease and cancer. So this action plan is really the first comprehensive approach to viral hepatitis prevention and really bringing together prevention of transmission and prevention of disease together for the first time as it relates to viral hepatitis. The story about hepatitis C began several decades ago before the virus was discovered in 1989 when it was known as non-A, non-B hepatitis. There were no, obviously, diagnostic tests at that time, and the number of reported cases was quite high, with over 200,000 to 300,000 persons being reported every year with this form of hepatitis. With the discovery of the virus, which became to be known as the hepatitis C virus, blood tests were developed to screen the blood supply. The epidemiology was better defined, showing it was a blood-borne virus and less often transmitted sexually. And prevention strategies were put in place, particularly related to injection drug users, for the most part directed mostly toward HIV, but has also had some effect in preventing HCV transmission, although not to the same extent. The incidence has declined in response to those prevention interventions. We estimate between about 15 to 20,000 new cases of acute hepatitis C every year. That incidence declined through the 90s into the early 2000s when it plateaued, and then just recently we began to see an increase in the number of case reports from a number of states that is beginning to show up in national data. Some of that is because we put out some extra money that we were fortunately able to obtain over the last 1 to 2 years for surveillance that might have explained some of this, but it does not explain all of it. One of the first states, and I'm sure Dan and Al are getting tired of me showing this slide, but they were the first to note this increasing number of case reports among adolescents and young adults. So that peak, that faithful peak of persons who were infected prior to the discovery of the virus, and albeit that about 70 to 75% of persons once infected remain infected, you have this faithful age curve moving through time, as evident on the slide on the left, and that's now being joined by a peak of younger, as the number of case reports among younger persons are on the increase. So we have a second generation phenomenon in Massachusetts, now found in Pennsylvania, Wisconsin, and a number of other states. But we're here today to talk about, and so let me just say that, screening based on risk continues to be important, as many of those incident cases, 60 to 70% of those are related to injection drug use. And we will be having a meeting with NIDA at the end of this month to delve into more detail about that population. But what we're going to talk about today is really this phenomenon of this population moving through time, progressively becoming more ill from hepatitis C virus infection. If you look at the estimated 3.2 million persons living with hepatitis C based on NHANES data, about 3/4 of those persons were born between 1945 and 1965, infected at earlier parts of their lives, many through drug use practices, some through blood transfusion, some through unsafe infection control practices in medical care settings, and to a much lesser extent through sexual transmission. This group represents 3 out of every 4 cases of persons dying from hepatitis C, and they have a prevalence 5-fold higher than other adults. Hepatitis C is a major cause of morbidity and mortality, and unfortunately increasingly so. Over 1 out of every 3 persons on the liver transplant list has hepatitis C infected. And if you look forward to the day where you could actually prevent that end-stage liver disease, that liver that's not used for someone with hepatitis C can be used for someone else in need of a liver transplant, as that is about a 20% mortality rate of persons on liver transplant waiting list. About hepatocellular carcinoma is on the rise in this country, about 2 to 3% incidence increase annually, one of the few causes of major numbers of cancer deaths that's on the increase. Liver cirrhosis is going up if you look at VA data among veterans, because they have a very excellent case registry system, and we have increases in mortality. And all of that translates into increased health costs and cost to society through disability, loss of productivity, et cetera. As was mentioned by John, in 2012 we published an analysis comparing associated deaths from hepatitis C to HIV and hepatitis B, and showed that there was about a 50% increase in mortality between 1999 and 2007. And in 2007, the number of deaths associated with hepatitis C surpassed those from HIV/AIDS, and that disparity has only widened in 2008. Our computer models show, as have a number of other models from other groups, that this mortality and morbidity mortality is expected to continue for the next number of years. In this model, we estimated that over a course of a lifetime, over 1 out of every 3 persons living with hepatitis C now will die of a hepatitis C virus-related complication. Almost 1 million persons. So our opportunity here is, how do we bend this curve? Are we going to let this curve happen to whatever the reality actually is, or are we going to be able to intervene to flatten this curve? Because the good news in this is that we have advances in HCV therapy. In contrast to HIV, hepatitis C virus infection is curable. Therapies are available now which can clear the virus. We've had the first direct-acting agents, the first antivirals, which Don will be going into great detail about, just licensed in 2011, and the pipeline is very robust for therapy to be even more effective and safer in the future. And so the benefits of knowing your status and being in care are increasing over time. Our recommendations up until August of 2012 were really focused on modes of transmission for the most part. Who's at risk of becoming infected? Injection drug users, for example, persons who received unscreened blood products. We also added persons who had evidence of liver disease, which is striving to incorporate hepatitis C testing into differential diagnosis, and persons with HIV are recommended to receive at least one time a test for hepatitis C. However, there's some real barriers to using that as your only strategy, particularly for this large population of persons who are very much removed from their point of exposure and transmission, several decades, in fact, and that risk solicitation may not resonate with them, or the physician may not even consider it because it's just not the reason they're in the office and fits their perspective of what someone who has risk behaviors for hepatitis C looks like and has as their clinical presentation. So we estimate, in looking at a variety of different studies, that between 45 to 85% of persons in the United States are unidentified. To give you one example from the NHANES survey, where persons are tested because of that participation, and then we go back out and ask them, did you know your status before you did participate? When you go through that metric, and this has been published by Maxine Deniston in our group, about half the persons said they were unaware of their infection before they participated in the survey, and then of those who were aware of it, only 4% reported being tested because of a risk factor. So we wanted to do, so in a moment of rising morbidity and mortality, fairly large population moving through time becoming more ill, most people not knowing their status, at a time when treatment opportunities are increasing in effectiveness and health benefit, we wanted to see what were the merits of moving toward a birth cohort strategy of targeting these persons born between 1945 and 1965 with that elevated prevalence and mortality risk. So we went through a grade-based evidence review. This was done by Jeff's team and Bryce Smith and Rebecca Morgan, who's here at the table, and with others, external persons, as part of an expert panel that we convened in August of 2011, put a proposal together looking at the benefits and harms, identifying that the benefits of testing linked to care and treatment can reduce the risk of all-cause mortality by 50% and the risk of hepatocellular carcinoma by 70%. We then put this out for peer review, put it out through review by HHS, public comment period, another round of review by HHS, and then published this in the MMWR in August of this past year, and published an abridged version in the Annals of Internal Medicine this December. So the recommendation is that all adults born in these years should receive a one-time HCV test for HCV without the need to ascertain risk factors. I didn't go into great detail about this, but one of the more powerful cofactors for disease progression for persons living with hepatitis C virus is their alcohol use. And the more alcohol you use, the biggest cofactor it is. And so we inserted that if someone is found positive, they should receive one of these well-evaluated, brief clinical interventions to assess alcohol use and to begin counsel persons as to how they should lower that use or even stop it altogether because of their HCV infection. With this intervention, we estimate that we could identify up to 800,000 persons who currently are unaware of their HCV infection, avert over 120,000 deaths from hepatitis C virus. That's based on current treatment effectiveness and current rates of persons being placed on treatment after they've been diagnosed and entered into care, which is still a minority of persons who are in care. all of these benefits at a very favorable cost per quality adjusted life year gained of $35,700. This is based on 3-drug therapy, which is the current standard. With that intervention, as shown here, compares quite favorably to other interventions that are well accepted and recommended in many of these cases as a clinical preventive service. So that's pegylated interferon ribavirin plus the telaprevir was the sort of the one of the 2 direct acting agents used. We also modeled pegylated interferon ribavirin alone, which is shown in the other bar. The other component of this is that the U.S. Preventive Services Task Force also puts out clinical preventive service recommendations, as I'm sure all of you know. They're going through their own process in updating their recommendations, which were last put out in 2004, which they had an eye for insufficient data to have any recommendation. They put out their provisional recommendation at the end of 2012, giving a category, a grade B for testing persons based on a risk factor such as injection drug use, and a grade C for HCV testing of adults born during 1945 and 1965, acknowledging that this would have at least a small benefit for this population. The challenge is that the grade A and B under the Affordable Care Act is a no copay preventive service, which would help support testing. We'll be meeting with payers in March. It'll be interesting to see how much, how they view supporting hepatitis testing already. Some of the ones that we've already spoken with say that testing for hepatitis is such a small cost that they don't red flag this now. So it's the biggest issue is that grade A and B recommendations tend to be those that have performance measures developed around them to stimulate best practice and have clinical decision tools like pop-up reminders for clinicians as considered a good investment by health systems. So this is something to work through. But we work very closely with AHRQ. We have shared expertise across these 2 efforts of developing policy, and they're still in a draft mode and are still gathering additional data. Because I think one thing you'll see from Don's presentation is that this field is moving very rapidly, and the committees like the task force have to be aware of these advances so that their policies will make sense in the near term. So as you all know, CDC, when we put out a policy, we do try to work with a variety of stakeholders to implement them, and that's why we're here. We had a meeting with major professional organizations. You'll be hearing a little bit more about that later. But we have really developed an implementation plan to really have this policy pay off. Have more people tested and into care and treatment, have more people placed on treatment as appropriate, so that the morbidity and mortality from hepatitis C will slow in its increase and maybe decline over time, for the right reason, not because this large prevalent population is becoming ill and dying of liver cancer, but because they have been treated, their virus has been eradicated, and their risk has been substantively reduced. Jeff will be talking to you in a moment about the variety of activities that we have in the areas of education, prevention research, development of demonstration projects, changes in our surveillance approaches so that we can continue to develop the best policies, guide implementation of those policies, and particularly with the use of surveillance data and prevention research information to help us identify the feasible strategies toward making this policy as beneficial for the persons living with hepatitis C as it can be. So I look forward to the discussion. Thank you again for coming, and all the best. Thank you.